It's red. We're good?
Good.
Okay, thank you all for your patience. It's 3:40. We're just a few minutes late to start our special called meeting, but we'll do so and get kicked off with a roll call, please.
Commissioner Patton is absent. Commissioner Barwick is absent. Commissioner Webb.
Here.
Commissioner Stecklin.
Here.
Mayor Absher.
Here. Would you all stand and join me in the Pledge of Allegiance? Chief, lead us off.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, next is our opportunity for people to address the council, which is a part of any special meeting or regular meeting. So if I would ask if there's comments that employees have that's healthcare related or to this germane subject for this meeting, we'll give you an opportunity to ask that later. So this is more for the general public. Is there anybody here who would like to address the council? Okay. Before I introduce our guest from Hope Trust, which is the subject of this meeting, I read a book several years ago, maybe some of you have read it, by a great author, and it's called Start With Why. I try to keep that in mind all the time, and so I want to make one more run. I know there's a union representative here or so. We're in the middle of a couple of union contract negotiations, and I've had the benefit of saying this 2 or 3 times, but since this is being recorded, I hope employees can listen to this in a broader scale than that, because I wanted to give you a little bit give them and those that are here a little bit of history, at least my perception of why we're here today, why it's important that we are here today, and more importantly, making some adjustments to some things. There's been a very high, or a long history of high, what the industry calls utilization of our health insurance. What that means is high claim amounts. In the 6.5 years that I've been here, that's not slowed down at all, and I've been told that we've been on this trajectory for 40 plus years. Health insurance is the city, as an employer, as an entity, it is our second highest expense to payroll. And just like any household budget, just like your budget, there's only a finite amount of money to go around that's available to the city to fund anything. It's the same way for the city too, just like your personal budget. Projected costs for health insurance in the future are very likely, not only based on our claims experience, but just what the industry is seeing, they're very likely to outpace our ability to keep doing what we've been doing in the past. For the last year, Cody and I have invited at least 6 carriers to look at our group health insurance. We've received a few proposals and a couple of "we can't help you" responses. For all the employees that are here today or that are watching and listening to the video of this meeting, if you do not take away anything else from my comments or theirs, please listen to this. There is absolutely no magic bullet with any carrier to come in here and offer us cheaper premiums than what we've been paying. Every carrier or an underwriter is going to base next year's premiums based on at least last year's claim experience, or in some cases the average of the last 2 or 3 years. The problem is not our premiums. The problem as a group is that we're spending nearly twice as much on our health care as some of our peer groups per person on claims. There's no other magic set of math that will refute that fact. We're spending twice as much as most of our peer groups. Now, we're not alone in this plight. I'm going to give you something I just researched today about the state of Illinois' group insurance plan. Fresh off the internet, I hope this is correct. Their quality care health care program, CQHP, that is their major medical program, has projected premiums to go up 11% for fiscal year 2025. Their HMO medical and prescription plans going up 18%. Their open access plan, 21.5%. And the prescription drug plan, the QCDP plan, is 36.4%. That's state of Illinois, and that's a pretty, in the government world, that's more representative than just saying, well, I've got a buddy that works for this or that private company. In the government world, the health insurance is a different experience. And that's kind of what at least state of Illinois is seeing. Last year, through Blue Cross Blue Shield, the original proposed rate increase was 17%, 16.9, I believe, to be exact. Through some adjustments and some negotiation we made, they whittled that down to 7%. So kind of the best case scenario looking forward is a 7% inflation rate, in my opinion. Nobody can predict the future, but let me give you some stark math. We believe the cost of a family health insurance plan to the city, which if you're employed here, you know, the city pays 75% of that premium and the employee pays 25% of that premium. We believe for the forward year that we started in January, whether we stay with Blue Cross Blue Shield, whether we go with Hope Trust or anybody else, again, nobody's going to come in here on a white pony and offer us $500, $600, $700 a month less than what we're paying. Not when our claims are more than our premium. It's not happening. Ask yourself why anybody would do that. So we believe that family insurance plan is going to cost $45,000, plus or minus. We don't know the number. But more importantly, let's assume a 7% inflation rate, which, like I just said, we had to negotiate it down to that rate this last year. And I just told you what the state of Illinois is experiencing this forward year. In 5 years, that family plan is going to cost just a hair under $63,000. In 10 years, it'll be an $88,000 plan. At 11%, if you went somewhere in the middle, $45,000 becomes $75,000 in 5 years. It becomes a $127,000 a year plan in 10. We've been in office 6.5 years. 10 years isn't really all that long. I don't think, if you think we can't, you employees I'm talking to now, if you don't think you can afford it now, and I'll agree with you, it's unaffordable. Try paying 3 times to 1 of what you're paying. It's unaffordable for the city too. Imagine what happens when that plan becomes a $120,000 plan. You don't like that number, cut it in half. Assume that I'm all wet and there's no inflation with healthcare. It's the path that we are on is wholly unsustainable. It cannot stay in place. So if the problem isn't the premiums, the problem's the claims, then the goal has to be containment of those costs. What does that mean? Well, whether that's through we work through vendors to negotiate better deals with hospitals and healthcare providers, whether we sit down one-on-one with every employee and their family and go over their specific situation and try to find if there's any other alternative that makes better financial sense for them, their family, and the city, whether we tailor coverages so that they're to their financial benefit, education on how we attain the most cost-effective health care, not just going wherever you want to go and whatever they say the cost is, you say okay, or don't even question it, just hand them your insurance card, when the place right down the road might be just as good or better and half the cost. Or initiatives for preventative care and wellness of our employees. Of all the companies that Cody and I heard from, come on up, Doug. Cody and I feel that Hope Trust has the best-in-class personnel and strategies to effectuate just those kinds of things I just mentioned. They can't promise lower premiums. They can't promise that we'll save money. I don't think you'll hear that from them today. They were clear and transparent with us about that from the very beginning. Because after all, they told me what I just told you. The premiums that we pay are solely based on the claims experience that we have. The name of the game is try to figure out how to mitigate our costs on the claims side. And before I introduce them and let them give their expertise and let us ask questions of them, I want to be transparent and give this message to all of our city workers and this family and their families. This council wants you to have health insurance. We want you to be healthy. But we also see the writing on the wall and have for a very long time. If we do not deploy strategies right now to contain our costs and yours in 5 or 10 years at this pace, we are absolutely going to hit a brick wall, maybe much sooner. No employee will ever possibly be able to afford health insurance, nor the city will, and our plan will collapse. And if that sounds too alarmist, I'm sorry, but that's where we're at. So it sounds really negative. I don't mean to be that. I mean to actually hold out some hope, pardon the pun, with the Hope Trust, that maybe we can find a way to deviate off of what I feel is a perilous course for us all. So with that, I'll let, so it looks like we've got a gaggle of folks here from Hope Trust. I'll let them come up in their own order and introduce themselves to the council, to the public, to our employees, and welcome. We appreciate you being here.
Yes, I drew the short straw, so I'll speak.
Would you mind coming up? Yes, please.
Okay.
If you wouldn't mind to make an effort to speak into the microphone, not that we can't hear you, but it picks up
Sure.
better for the video.
Sure. Well, thank you. First, thank you for having us here to your city council meeting. My name is Alex Snedeker with Snedeker Risk Management. Real quick, I want to introduce some of our teams. So this is what we consider our field team, our eyes and ears out with our clients throughout the state. So we have Ted Whitehead here, Jake Jansen, and Brent Williams. So Jake lives here in town. Brent lives just south of here. But our firm, a little background, is we specialize in local governments throughout the state, primarily Peoria, south to really the border of Kentucky. So we don't get up into collar counties or anything like that. We're downstate. And when my folks started the business, we were your traditional local insurance company, from crop insurance, homeowners auto. We've sold most of those firms off, and 100% only do local government now. I joke with people, I don't even insure my own home or cars. But what that has allowed us to do is do just what you said, really focus on the issue at hand and specialize for our local government needs. So half our division does the property casualty work comp, our brother's side. My side of the division does health insurance. So it is a very expensive topic. It is a very complex topic, as the mayor brought up. I couldn't agree more. He's right. The first time we got called in, it was pretty apparent. I try to make it known. We will not buy the business. That is not what we are here to do. So what I am bringing here today is known as the Hope Trust. So a little background and make more sense. Hope Trust stands for Health Options for Public Entities. And it is an intergovernmental co-op, so just see it as an insurance company that is made up solely of local governments in the state of Illinois. So 4 counties started it. But right now, there's over 30 entities. I want you to think of counties, cities, and schools. We have a couple other housing authority, a couple other things like that, but for the most part, it is really counties, cities, and schools who make up the Hope Trust. So Jake did bring some packets here. If you want to come up and grab some of these flyers, or grab them before you leave. This is just some information that we prepared for everybody, if you've not already seen it. So one of the things that we like to hand out is what we call just a one-page, I call it the mission statement, and it just gives the background of the Hope Trust. So roughly 15 years ago, we created the Hope Trust. As I said, it started with 4 small counties coming together. We were slightly over 100 and something employees total. That's a fraction of your whole group, but that's what we started with. And it really was nothing more than banding together as a family, working together for a mutual goal. It has since grown to over 5,000 employees and their families throughout the downstate. Many of the counties around here we do have in the trust, and that's very helpful, and we'll get into some of that here in a minute. But just a few notable highlights that we like to brag on the trust. As I said before, while we created the trust and we are the administrators of the trust, we'll never own it. We're the hired help. So if there's something that needs changed, if a labor group or a subset of employees have a request, they're open to send those in, and that's exactly what's happened through the years. So maybe there's a coverage that they've wanted to get included. They bring it to us, many times we are able to include that. And so I want everyone to really understand how the trust is made up. It is owned by the members, so by the entities. So if a county or a city joins, you have ownership in the trust, and you really tell us what to do. So that has been a great benefit through the years. We have virtually 100% retention in 15 years. I like to brag that each representative has a spot on the board. They elect an executive board that gives us our marching orders. As the mission statement says, one of the big goals was to really, like any insurance program, merge together and try to create stability. And we've done that. Is it still expensive? It's terribly expensive. I mean, I don't know, if anyone comes in here and says that they're gonna give you a good health insurance program and it's cheap, I would not be listening. This thing is anything but expensive. Where we really seem to rise above is instead of having those 7 to 15% increases year on year, and depending on what study from Mercer to Kaiser, that's probably what you're gonna find. And I think that's true. So, you know, somewhere around that 8 to 12 range is what the average entity has seen over the last decade or two. You folks, if you're covering yourself and your family, you've seen the same. We all have. I have in my family. We try to aim a little bit above, so if we can do 3 or 4%. So you say, well, that doesn't sound like a big difference. Well, give us 10 years and it does. So we just had our annual conference last week and brought roughly 150 or so elected officials, various labor groups. We were humbled to have a lot of our labor, FOP, to laborers, to AFSCME, all present at our meeting. And one of the slides that we showed was that in our 15 years, our cost of coverage has went up 41%. To me, that's still a huge increase. But when you look at it from a year on year, we're roughly 3%. And I think that is the story that has to be told. So are we able to keep it flat for 15 years? No, but we are able to beat the industry. And it's not just because of what we're doing, it's really the groups banding together and negotiating some pretty impressive things, and I want to get into that. But again, those are real life numbers that I wanted to use. A couple of things that make us different is, since you own the trust, if there are reserves in excess of what you need, those are going to be sent back. That was another highlight of our recent meeting. We were able to announce the 3rd dividend. So granted, in 15 years, we've only been able to do it 3 times, but as I asked the members, is there any other health program in the state of Illinois that you have heard of, from Blue Cross to the state of Illinois, local government health plan, Health Alliance, that's ever paid a dividend back? Because I'm aware of none. So we, at least in 3 of the years, have announced dividends to be paid back to the group. This last one was a little over $365,000. So, you know, it's not huge amounts of money, but we're pretty proud of how, you know, strict we carry our budgets and hold together. And now we're going to really jump in, if we can, take a few minutes of, well, how do you get this? How is your mousetrap, if you will, better than the rest, at least in our opinion? One of the things, and we spent a lot of time when we first met with the city, you know, of course I had an agenda of what I wanted to, you know, cram into the mayor and Cody's mind of how we're different. One of the things that really sets us apart in the trust is we have the same constraints that anyone's had. Whether you're a Blue Cross or self-funded, it really makes no difference, folks. We started seeing escalating costs in the late 2018, 2017 time period, just like everybody else. Again, remember, the trust was founded to try to do single-digit increases. We knew it was still going to be expensive, and we knew we were still going to have increases, but we really had hoped, could we do single-digit? Well, around that 18 period, we just started seeing our claims funds were being utilized more than what we'd like. We're going to have double-digit increases. Not terrible, but more than what we wanted. We started looking at the numbers. The trust, of course, had started to grow pretty significantly by then, so one thing we have is a lot of data, a lot of claims data. And the one thing we noticed is we used an off-the-shelf network. I would say in Illinois, in this part of the world, your 2 biggest networks are Blue Cross and HealthLink. And we used HealthLink. Great network for saturation. You're hard-pressed to find a doctor or a hospital that doesn't take HealthLink. The problem we had is that we were seeing huge variations in our reimbursement on claims. And what I mean by that is If we had a member that was here in Marion, and I'm just going to use this as an analogy, so please, this is not real data, but what you do have is 2 hospital systems. So you have Deaconess here in town, but you still have a huge presence of SIH. So we would see a member go and get, let's just say, an MRI or CT scan at SIH. And it doesn't really matter what the bill charge is, because no one pays on bill charges. You get, remember, that network discount. We all know how this game's played. But we would net pay one hospital, say $1,500 for this procedure. The same exact claim, just a mile down the street, under the same network, same tier of network, we may pay $5,800. That was very problematic to us. Now remember, this is just one claim on one member. So could we handle that? Sure we could. It wasn't going to bankrupt us. But remember, when you start having thousands of members and hundreds of thousands of claims per year, it really got our wheels turning. Is there a reason that we're having such disparity here? And if we could get that under control, could we maybe save the trust from having those double-digit increases? Very frankly, we were just that naive and dumb that we thought we could do it, and we did. We went out and we built our own custom proprietary network of providers. It started small. I really have to thank our membership for being patient with us. But as we sit here today, we have grown a very expansive network of providers that spans about 4 states. So while we're just in Illinois, as you know, our members who especially live on the border, but we're going to go to St. Louis. We're going to go into Paducah. And we're going to go into Deaconess or Vincennes. So we still have to contract with all these health systems. That has allowed us to get control, though, of our claims. We have agreements that in most cases are based not on a billed charge amount. We actually price off of Medicare, which is very rare as far as the size of network we've created. And as we really went into this pretty in depth with the mayor and Cody, they probably thought it was too much. But long story short, it has allowed us to stay very consistent with our claims, because one hospital has not been able to manipulate their charges or their discounts in one way or another. So we see very stable reimbursements. We like that from a transparency standpoint, because remember, where's the money coming from? It's taxpayers and the employees that are throwing in on it. So we guard it very carefully. We don't think that paying one hospital 4 times what we pay another one is proper if it's the same care. Over the last 5 or so years, that's one of our biggest probably benefits that would set us apart. So if you were to go ask folks from Williamson County, Union County, Jackson County, what are some of the things that this Hope Trust that you would like? I would guess our members would bring up the network is probably in the top 3. Because the benefit of the network, now that we really know how we're pricing things and what we're going to pay on the front end, even before the claim happens, we're able to bring transparency to the members that they've never had. What I mean by that is we tier our network. So if you're a provider that has agreed to terms that we would consider are pretty fair or value-based, we tier them tier 1, preferred. And if our members go to those providers, we virtually waive 100% of their cost. So even if they have a $1,000 deductible and $2,000 out of pocket, it's 100% free, even for diagnostic, to go to preferred. One thing that we didn't know when we started, but it's been a real blessing, is that virtually 90% of all of our providers. So we contract, it would be probably over 10,000 different providers over the 4 states. But yeah, roughly 90% of those are all preferred. So in certain areas, Marion is one, you will almost be hard pressed to go and find a standard provider. Whether you go to SIH, whether you go to Deaconess, whether you go to St. Louis, we have virtually all of those hospital systems as tier 1. There's still some standard out there, and it doesn't mean that they're bad providers. It just means that they haven't yet agreed to terms that at least we know we can control, or that we feel are value-based, they're fair reimbursements. So that's a big deal. So what I mean by that is, for a lot of our members who are now under the Hope Trust, they'll be very frank with you. Years before, my family and I, not only did we have to pay for the coverage, but we had to budget, $2 or $3 or $4 grand a year and out of pocket. We very possibly would have eliminated that for them. So that's been a blessing, and we're pretty proud of that with the trust. So that's a big caveat that's different. The other things that we have done with our growth, or been able to do, I should say, is where we're unique. is a lot of the services that I think are value added. So maybe it's concierge care if you need help finding a provider, or getting a claim question answered. We've been able to bring all of that in-house, and it didn't happen overnight, but over the last 15 years it has happened. So we actually have our own clinical team that's on staff, and virtually 100% of their job is to be there to help the Hope Trust members in anything that they need regarding their medical or pharmaceutical care. We don't force it upon you, so if you've got a local provider that is willing to spend that time with you in the office and help you do everything, great. We're not looking to intervene, but as we all know, too often that's not what we have. We have a provider, your local primary says, well, you need to get this done or look at getting it done, and you're out the door. So then, well, where do I go? Where am I going to go, as the mayor said, to get the best care for the best price? That's never been able to be done. I mean, remember, only public sector can be in Hope Trust. So my firm is private sector. So legally, I can't even be in a trust. I would kill to have this coverage, but I can't. We have a Blue Cross policy. But I can tell you right now, if I were to pull out my phone and call Blue Cross, there's no one that's going to be able to tell me where to go get my cardiovascular care done at. And that's after I wait on the phone for an hour. Because I've been there. I have a family and kids. So we have to go through this. So the clinical team has been a huge lift to help our members when they need it. Of course, on the back room, we are looking at claims. We're able to diagnose, help folks get to providers that may work better for them. The other thing is we have our own customer service team. And so that helps too, if a member has a question on a claim, which is very common. This is not easy stuff. It's very complicated. I have to look at stuff for my own family. So those are some of the added value benefits of the Hope Trust. So we have a lot of that in-house. Last year, as we shared with Cody and the mayor, we weren't happy with the vendors that were even processing all of our claims in the back room. So we made the decision with the executive board to actually bring all of that in-house. And while that was a huge lift, it's really given us that much better ability to help our members and their family navigate the healthcare system. It's been able to help us from an entity management standpoint so that we can bring claims and projections, because all the data basically flows through our servers. That doesn't mean we ever disclose PHI, but of course we can't. We're going to guard members' health information just like any other carrier. That's the law. But we can at least get access to those numbers. And I can't finish the mayor's sentence more is, if you think you're going to make this stuff cheap and keep it at the level that we all want for our families, that's never going to happen unless something changes, and I don't even know what that would be. But do I think we can stabilize it and get a lot more efficiency out of the healthcare? You bet. We've seen it, and we've seen it over the last 15 years. And I think that would be the story if you do reach out to, whether it's your coworkers, colleagues, and other entities, whether you talk to other elected officials that have been with the trust. I think that would be the story they would tell you, is that we've at least been able to get control. We average that 3 or 4% per year, and that does really help us on a budget standpoint when we're setting levies, et cetera. So I did include some sample summary sheets. Like most carriers, I mean, we abide by the ACA like all carriers do. So, there's no magic wand here that, well, the trust, maybe doesn't cover orthopedic surgery. No, we have to cover what everyone does under the ACA. It's in the margins where we're different. But we do think these summary sheets are pretty nice. So, I can dive into them. We can go through them. I don't know how much time we want to allocate. And these aren't the gospel. We have a plethora of different plans. We threw in a couple that we thought would either very much be similar to what you either currently have, or what we found other like-kind entities they choose as secondary options. So that's something that we may bring up to the staff and to the council. Many of our groups do allow what we call dual choice. So they don't just pick one health plan and say, oh, every employee, you've got to take that for your family. Because I'd argue there's really not one plan that works best for everybody. So we allow the dual choice. They may cost different amounts, but they work differently. So one employee may want that drug card. They just feel more comfortable about going and getting their drugs and having a copay, and they're good. Another employee may say, you know what, we're not on, my family's not on any drugs, we go get our annual checkups, but it's been 5-6 years, we've never had any care. They may want to hire level deductible and save on that premium per month. And I think that's a very valid argument, quite frankly. So we do try to at least bring that, but it is the entity's choice. You don't have to offer dual choice, but it is, it's at least something we can offer. So I wanted to bring that up. There's a couple little caveats that are a little different with the trust. The executive board many years ago, because you got to remember, many of our executive board members have a Hope Trust ID in their wallet or purse too. So, they want really good coverage. And one of the things they saw is that all too often, they didn't feel a lot of the employees had enough life insurance. So we built in a standard life insurance policy to everyone's coverage. You don't elect it, you don't pay more for it, it just comes. It's $20,000, so it's not $1 million, but it is just a little bit added value for the staff. Unfortunately, we've had to use that at times, and it is concerning when you talk to the widow or the spouse that says that's all we had. So I'm at least glad that we could offer that. So there's just caveats like that. We talked about the network. I think being able to either greatly reduce or completely lower or get rid of all of your families out of pocket by going to our preferred network and knowing that SIH, Deaconess, they're all preferred. I think that would be a big game changer for the members here. I've not seen the claims know where you go, but we have most of the counties around here, so I don't think your members are going anywhere different than where they're all going, whether that's Williamson or Jackson or Union, Pulaski, Johnson. We're all going to those similar like-kind entities. So that's what we've seen there. We do offer some other plan options that typically your fully insureds don't offer. And what I mean by that is if we have a plan called the HRP, Health Reimbursement Plan. That plan is for folks that may have other group coverage available elsewhere, typically through a spouse, but it doesn't have to be. You could be a retired state unemployed employee. So you actually have coverage to the state if you want it. That plan is elective, but it comes at a great reduction of cost and will cover your whole family. So typically 15 to 25% of all of our members in an entity. So if you have 100 lives, 100 employees, 15 to 25 of your employees will electively take the HRP. So, and that's something we will go over. We usually like to sit down with the employees so that they really understand it. We always encourage them, go home to the kitchen table with your spouse, pull your last 2 or 3 years of medical expense out, see what you're spending per year and see if the HRP makes sense. But for 15 to 25% of your staff, you don't currently offer it, but I would argue, we'll probably find that here, they're gonna be better off on the HRP. It's the best plan we offer. And you say, how is it better than the major medical? Well, if you have other major medical available, use it. Use our HRP, and it's kind of a wrap plan. It fills in all the gaps of you and all of your family. So even if you have a child or a spouse that has $3,000 of drug expense or a deductible for that other plan, you send it to us, we reimburse it 100%. What you do with it's you and your family's business. So, I always say if you were to interview some of the Hope Trust members that have been on the plan for 5 or 10 years, what are some of their top things that they would say? That would be a network. I would say the customer service, kind of, seeing the guys come out in the field, always be there to help them. You get their cell phone, that's a big one. And then the HRP is probably another one. They would say that's just been, most of them say it's too good to be true till they get it, and then they're never going to get rid of it. They absolutely love it. So another different option that the trust can bring that's really tailor-made for the public sector employees. So I don't want to go over too much and inundate you, but I want to be here for questions. I certainly want to be here if any questions of the members or the dependents. Is there anything you'd like to go over in more detail, Mayor, Cody? We've spent more time going over this, but I want to make sure we hit the high points. But if there's something you want to spend more time on, I'm happy to do it.
I've got one that I'd like to address without getting into the weeds of percentages and stuff. But, so our closest example is Williamson County government, which I 2 years ago went with your plan.
Yep.
Well, we were here then, and we don't have much to do with county government, but we know lots of people that work within county government. And let me just put it this way, there's a lot of drama around that at the time. We were hearing all kinds of things. You never know what you're hearing is good, if it's half truth or the whole truth. But let's just suffice it to say there's a whole lot of drama. Everybody was up in arms. Flash forward 2 years, all I'm hearing is the leadership at the counties talking about how they've saved money. And I'm not hearing any of that drama. Everything I'm hearing is everybody loves it and encourages it. So assuming we would have the same
Yeah.
trajectory, can you give us an expectation of what that drama was like? You nodded your head, so you must agree.
Well, I
that it was
laughed
dramatic.
because my field team chewed my rear end and said, "You sent us into the guillotine." They were
Okay.
hostile, and since then it's great. You're right, but if I can give you a little bit of background, I
Yeah,
think
just
I have
walk
an
us through
explanation.
what that looks like.
Yep, so let's go back 3 years. And if any of you have family or relatives that are friends that work at the county, this will make sense. The county for many years was with what we call the local government health plan. So this is health insurance for local governments. It is sponsored somewhat by the state. I'll be the first to say it is phenomenal coverage. It really is. It has been for 30 years. The problem with the local government health plan is it is very expensive. Very expensive. And the county was experiencing very much of what you did. I mean, they were getting, I think it was something like a 17. Don't quote me, talk to the county. I think it was certainly a double digit, 13 to 17+% increase. And just like you, when you're dealing with millions of premium dollars, we can't just keep taking this. And they may have had that for 2 or 3 years in a row. So they love the coverage. Of course, the staff, as you can imagine, and if I were them, I'd be saying, whoa, this is great coverage. They were very much concerned about changing. And can you blame them? I mean, they had top tier coverage. The reality was the cost. And so that was, and I think if you were to ask any of the employees, the labor, or even the officials, they would say that, no, that's accurate. That's what happened. So yeah, through the actual change, the county commissioners didn't really have that much of a choice because they were in the same boat. We're gonna run out of money. We have to make some changes here. They didn't want to cut coverage. So they really went above and beyond to make sure that there was as many plan options. You know, if this trust is honest, you're gonna save money, employees. It's actually gonna be better. But no one likes change. And that sounds good in a meeting, even though we went and did a lot of these, we did a lot of educational seminars, but the rubber hit the road. So through the actual changeover, when it happened, I think these guys right here in this room were hit with a lot of just fear, quite frankly. I mean, they can speak for it. I wasn't there. I sent them in. I'm not smart enough to do that. So they took a lot of that, probably fear, anxiety, frustration. But jump ahead, and this came up actually at our conference last week because we had a lot of the labor represented. And they used Williamson and said it was. They got a lot of flack and they fought hard, like, you know, what are we gonna do? And that was their point, is that now if you go to the county and say we're gonna leave the Hope Trust, he's like, you get a fight like you've never had. So I think it just took them moving to the trust to find out what they said is true. When they said, if I go to, you know, SIH or I go to Heartland, it truly is free. Like, they're not lying. But until you have those claims and that experience, I think you're always skeptical. I mean, we just, you know, healthcare is expensive and it's hard to trust providers. So I think we just had some of that. That's my explanation, Mayor. I mean, feel free to ask anybody, but it was fear of leaving a very good plan, which I'll be the first to say it was a very good plan. Local government's a great plan if you can afford it. And so it's not that the county saved, you know, 50%. No, we probably saved them, I don't know, 7 to 10%. But when you're budgeting $4 million, it adds up. I mean, I think, yes, it was probably $400,000 to $600,000 their first year. I have no idea what Marion will have. I've not seen your claims. But it's the tools that we implore that do it. I'm not God, nor any of us here. You're gonna have your cancers. You're gonna have your transplants. What I can tell you is the Hope Trust is prepared. Our size is gonna help with that. We're big enough, we can handle some of those large claims to where if you're on your own, you can't. It's gonna hurt. Even a $4.5 million plan you have now, we have RX therapies that are $1.5 million for one person. I mean, even your size plan can't handle those kind of hits. Well, when you become a $50 or $75 million program, we can buffer some of those. More importantly, we have some really neat mechanisms in place that I discussed, whether it's our network or clinical team, to where we can try and work to mitigate those losses. Do we still pay tens of millions in claims? You bet we do. But do we dodge tens of millions in claims? Yeah. Yep. But we work very much in the weeds. Our field team is boots on ground, whether it be Williamson or Jackson or any of our other entities. Throughout the year, we meet many times with insurance committees. We meet with the labor representatives a lot. We see it as a family. We're a little unique. I know it sounds a little quirky to say that, but once you're in the trust, I think people they really do treat us like family, and that's how we see it. So that's my best explanation for Williamson. But I do think if you were to ask, I can't promise to make everybody happy, but by and large, from all the employees we talk to, certainly the elected officials and even the labor representatives that were at our conference who oversee it all, were very complimentary and said that they don't want to go anywhere. So I think we've done well there, and we would expect Williamson to be or Marion to be similar. Some of that is and we can get as much in the weeds as you want. All of our network contracts or our direct contract with the providers, so just think the health systems or doctors groups that you have. They're all in confidentiality, so I don't disclose every little contract. But what I can tell you is by tiering them preferred, you can be guaranteed that we're getting great pricing. And because of our size down here, we're probably one of the larger payers. So we sit with management at these hospitals. It didn't necessarily happen overnight. SIH is a prime example. They were a tier 2 standard provider initially. They would not agree to the terms we asked, and we said, okay, we still shook hands, we had an agreement, but it was tier 2. Your deductibles, your out-of-pockets went through. We were not gonna encourage staff to go there. But jump ahead 3 or so years, we were able to finally sit down with them, and we came to just a great contract with SIH. And so that was a huge benefit for well over 1,000 members down here, that now they and their family can go there. So it's been a great partnership, and those are the success stories that I like to brag on. And some of you may have family that work there, but that's kind of the difference that we have with the trust. So,
I have 2 questions.
sure.
In regards to like SIH, a place like that added into the trust, I'm assuming at some point some of these providers can leave the trust as a provider. Do you see that much, or do they mostly, when they're in, they pretty much stay?
Yeah, it's in their financial interest. They want to stay because they want to grab the money.
Gotcha.
What we see is mergers. I mean, so take Heartland.
Right.
When we first contracted with the local hospital, they were under a quorum contract, as the name was privately owned, you may know this. And so, Deaconess later came in and bought, but they kept the contract. I mean, it's in their interest to do it. And so many times we're actually able to improve those sometimes. So, knock on wood, no, we don't see that. What we see is mergers and acquisitions. But usually our contracts not only get carried over, but sometimes they get better. And the larger we grow, we will, if it's still a standard contract, we're always pushing, north of Effingham, there's a hospital system that we're still trying to get switched over from standard to preferred. But no, we've not had a lot. I mean, because you can imagine they want members to go there. That's how they make money. And with how we agree to terms, it takes some of the juggling out of it. The other benefit, and this gets a little bit in the weeds, but if you were to ask the management at, say, SIH, why do you like the trust? One thing they're not holding is our debt. So I would guess that if you ask Deaconess or SIH, they're probably holding 10 or hundreds of millions of dollars of your fully insured, so your Blue Cross debt. And that's in claims appeals, they hold up prior auths. I mean, talk to anyone in management, they'll tell you that. And that's real problematic for the health systems, because think of the interest that they pay on that debt. The Hope Trust would pay our bills immediately. And so I think that probably garners us a little better reimbursement rate, quite frankly, Joe.
All right. I lied. I got a second.
Sure.
one.
No, go ahead. I'll sit here all day.
Sorry. When I was looking through your list of preferred providers, I noticed there's some individual physicians on here.
Yep.
Now, looking at this list, I see like 20. I'm sure, is there more than that? Or is this just a sprinkling of that? 'Cause
Well,
I happen to notice it because one of them's mine.
Yeah, this list, be careful with it, because there's not a lot of standalone doctors out there anymore.
Right.
So you get to a doctor, but it's not by finding Dr. Smith.
Right.
Dr. Smith works for a larger institution.
SIH or something, yeah.
And that's what I mean. So we only have probably around 1,000 contracts actually signed, but it covers tens of thousands of physicians and facilities.
That's
And so that's where the clinical team comes in. One of the things when we built our network that I wanted to avoid was, if you've ever used HealthLink, and I don't mean to throw in a bus, there are great networks for the saturation, a lot of doctors. One of the problems I had, though, when I went to try to find if this doctor's in HealthLink, is very complex, very hard to find that. So whenever we kind of build our own network, I wanted to try to simplify it as much as I could. So, you know, you may see, you know, a physician's group, well, they may have 600 doctors, and that may be who you're seeing, but it's just the one physician's group on there. So if you see just one doctor, then that probably means they're on their own, and so we list them separately. At times we have doctors contracted, we don't even put them on the list because you wouldn't, they're like a radiologist or, you know, you're not gonna go right to them. Your labs or scans are gonna be sent to them privately. So if we need to add, we can add at any time, and we would. I mean, there's gonna be a chiropractor or something like that that someone here in the city wants to use. We make that very easy. We can contract with folks very quickly. I don't see probably a lot of new need for physicians, just knowing how many groups we have around here now that if there's a doctor, we would have probably known about it. But there'll be a few that we may still need to add.
Okay. And my last question, I promise for now.
Sure.
Preventative.
Yep.
I know that's obviously one of the biggest drivers of our cost is getting preventive medicine in the forefront rather than on the back end of this. What do you guys, how do you encourage that with members? Do you have programs in place that meet with members and encourage them this way versus that way? Or
Yeah, I find preventative is coveted because under the ACA it's free. No, we would always encourage folks to go get their preventative care. I think there's not as much force on the trust because we want you to get your care no matter what. Just because even as a diagnostic, I want you to get your care. That's why if you go to preferred, it's free. Yes, preventative, we have to abide by the same federal rules as everyone else. Our clinical team is always going to push for you to get your preventative work. A couple little things that I do want to point out that maybe I should have in my first pitch, and it's up here. One of the things that we do, not so much preventative, but I think it does hit to the heart of where you're at, is many of our groups are still rural, so they may not even have an urgent or prompt care downtown. They may need to drive 20 or 30 minutes. So like a lot of health plans, we, even before COVID, offered telemedicine. This is 100% free to our members. So even before it was cool with COVID, we actually did it in the trust because we saw the need. So many of our groups, you know, again, if on a Friday night their child needed to go get care, they were going to have to drive 20 to 30 minutes. So if we felt, well, they probably need a steroid or an antibiotic at the local pharmacy, but they really need to drive into town and you know, go to the ER. So we offer telemedicine. A couple of years ago, though, we added, we switched to MD Live. That's been great, and that's for, again, diagnostic, you know, antibiotics, you know, need a steroid or something. The other side of this is behavioral health. And I have no idea what your group currently has. It's probably similar to my group, Blue Cross Blue Shield, quite frankly. But behavioral health's a big hot topic, I would say, in the US, and rightfully so. So this is another unique benefit of the trust. Getting to a psychologist or a psychiatrist is not always the quickest or easiest. Even down here, you're gonna probably be on a waiting list, and if you have a child, it's very lengthy. I would guess 30 to 90 days to get a child into a children's psychologist or psychiatrist. With MD Live, that was one of the reasons we chose them. Don't quote me, I think they go down to age 11. And so they can do even a lot of our children dependents, but certainly all of our adults. And again, 100% free. And the way it works is you really call, and within minutes, a provider will touch base with you. If you want to schedule a time privately with that psychiatrist or psychologist, you can do that, all free of charge and virtually real time. So for some members, that may be another, I love the trust because of that. Is that preventative necessarily? No, but I would argue, if you need the care, get the care. And whether that's diagnostic and again, an antibiotic, or that's a behavioral health. I think there's, you know, I think we all feel some of us would probably be better served with counseling than getting on more medication. Medication is just not working. We can spend a lot on that. With our clinical team, we probably do more to make preventative more of a hot topic, whether it be weight loss programs. We have an Active and Fit, which is a discount service for like gyms, memberships. So I think we do as much, if not still more than most carriers on that, but we are still a health plan. You know, we're not a fitness center. We offer some discounts for that, and we'll always encourage it, but we're a health plan, if that makes any sense.
Yeah.
Good questions.
Our high claims history doesn't scare you off then?
No, not really, because no one comes to us when they're having great claims. They come to us when they're having tough claims, and to be honest, that's where the trust shines because of our blend of like-kind entities. We still purchase a great deal of stop loss. We've been with our stop loss carrier for virtually 40 years, which is unheard of. So there's years we hand them, $10 million and they pay us 11. There's years we hand them $10 million and they pay us or pay out on 6. That's been a great relationship. But what that means for you is we're going to have big claims. I don't know when and I don't know on who, but you're going to have them. Every group is. I think our trick is to try to find them quickly, get them fixed as quick as we possibly can. Are there ways that we can mitigate that cost? If there's not, we still provide the coverage and then have reinsurers that back us up, A-rated companies that come in. So after a certain threshold, they take over. And that's any health insurance. I mean, Blue Cross does the same thing. It doesn't matter.
So if we was to join you guys, our cost stays in-house, or like the counties would go up because we took in Marion?
No.
So we're standing
every
alone.
group is looked at individually
Okay.
on your claims.
So our
Yeah, we still blend you together, and so there's been groups, we're still a risk pool, so, let's just say that Union County has a tough year this year. They're running well, but let's just say they were. Because they're with let's just say, but Jackson's having a great year, Williamson's having a great year, Johnson is, we will artificially lower Union's what should be their increase, because that's just how it works. We're a family of like kind. Does that mean we give them a pass? No, but it's how we do that 3 to 4%. Averaged out, it works. And it's worked for our firm for literally 40 years. Even though the trust has only been here for 15, we were individually self-funding groups well before that. And in the back room, we were doing that same principle, coming together. So no, you will be looked at separately. And that's kind of a benefit because you're gonna wanna know your claims. You're gonna wanna, what are we doing here? That's great that Jackson's running good, but I wanna know about Marion. You're gonna want access to that information, and we wanna be able to deliver it. Again, it's not gonna be on a John Doe or Jane Doe. We're not gonna get that level, but you will be able to see where you're running, and I think that's a benefit. Yep.
So, may I ask a question?
You bet.
Okay, so the gist of it, what my take on what you're selling is, so if you looked at Marion, I'm assuming you looked at Marion, our claims.
Mm-hmm.
Our claims, when they say claims, it's a dollar amount.
Yep.
And this dollar amount, whatever that is versus another town's dollar amount. Not necessarily the number of claims, but the dollar amount. So what I take from you guys is what you're selling is you've done the homework, you've done the research, you negotiated the contracts. So hopefully you can guide our employees to, if you head this direction, this heart surgery is going to be thousands less.
Right.
As long as you follow everything you guys have laid out.
Yep, we're gonna wanna work with you.
That's ultimately, I think, through, I don't know if it's education or just negligence, we've just had the ability to go wherever we want and pay X amount of dollars over here when we could have went to the next. And we've had that conversation. So that's kind of, you've done that for the employee.
Yeah, and you guys are really lucky because you're still gonna kind of get to go wherever you want because of how we've been successful. Not every spot's like that. So you go up by us and, I live at a little farm town outside of Springfield. Springfield has 2 health systems. One is preferred, one standard. So it's not like there's a penalty for going to the standard. It's not like, you're a loser farm. No, it's just your deductibles flow through. But the difference is yes, that entity and that employee and their family could save, in some cases, a significant amount of money by going to the preferred, and we do. We try to educate that even before the claim happens. You guys are really blessed here because we've got some great providers that, because you're governmental, because of our size, there's a lot of reasons, they've really sharpened the pencil and give you great contracts. But we'll still work with those members to get them the care they need. We can help them, get in the door, make sure prior authorizations, pre-certs are done, because if they're facing a cancer or something in their heart, they don't want stall, they want help.
So that's my question. If you look at Marion's history,
Yep.
Are we unique in the fact that, are we going to the doctor more, or are we just getting billed a lot more, and there's no checks and balances, there's not many checks and balances?
I don't see
insurance-wise?
Marion unique from, I think where maybe you feel unique is maybe other agents or brokers have came in who either didn't know what they're talking about or they deal with a lot of private sector. I think there are cases where private sector, let's just say a widget company, but their average age of a worker is 35. I would bet statistically that widget company is going to have lower medical costs because their average age of worker is 35 years old. We insure local governments in the state of Illinois, mainly central and downstate. Our demographics don't change much. So whether we're looking at the City of Marion or Williamson County or Jackson County, you're all gonna run very similar. Is it Marion gonna have its bad years? You bet. But if I looked at your claims, is it just gonna look so much different than Williamson? No, it is not. It is not. No, it doesn't mean you don't have work to do. Sure. But it's not gonna be that much different. So the question is, was he fearful? No, and it's not that I don't see problems, but it's I think we could work on. And from everything I've seen, which we've not seen a ton, Blue Cross provides what's called an insight report, and that helps. Don't get me wrong, it helps. But we would still look at it doing probably medical apps. They're electronic, they're HIPAA protected. You don't have to give them to your employer. It's all between us and the trust. That helps us gather that information to know what's out there. That along with, those reports, they're helpful, but they're not the gospel, if that makes sense.
Well, that would be my question. You wouldn't look at Marion's portfolio and say, Marion loves drugs and they love to go to the doctor.
I'm not
That's
saying.
what I'm
Could
getting
you
at.
please
I'm not-
rephrase
I'm not-
that?
I'm not
that's what
saying that.
That's what I'm trying to clarify
Yeah.
for the employees that are listening, because I don't believe that's the case.
I'm not seeing that. There's nothing on
But there
here.
is a possibility that we've been charged costs that aren't,
Alex, why don't you talk about
that's what I'm
Medicaid
getting.
reimbursement rates and how your
Yeah.
contracts vary from what Blue Cross?
Yeah, so the problem that I have, and I'm a very simple-minded individual, which you all figured out, so transparent and loud-spoken, but simple-minded. The whole point of these providers, and I'm not here to demonize hospitals, and you're really lucky with some great ones around here, but throughout the country, for 30, 40 years, we took a really bad side road on how we reimburse providers. And the way this works is, for the most part, you partner with the network, so in your case, it's gonna be Blue Cross. But they've made the decisions, and you're not able to go and see. Blue Cross don't want to tell you what SIH's reimbursements are, or Heartland, or Barnes, or anybody else. So they prearrange these agreements, and they just tell you go wherever you want. But when you start seeing that there are differentials in what that treatment would be, to me, that's problematic. I mean, you wouldn't stop at a gas station that had $21 per gallon gas, when everyone else is $3.50. We do that with healthcare. So my concern is less, I think we've somewhat been sold a bill of goods that, oh, it must be Marion has these big claims, or Williamson County. No, it could be that you're going to providers that are charging you, 3 times what other ones are doing it, and you didn't even know it. They don't give you the mechanisms to know this. That was concerning to me. So again, in around 2019, we started, and I'm very honest, we were naive. We were bullheaded and naive and thought we could maybe change it, and it took a lot of work. But that has allowed us to, the contracts are now in your hands. The Hope Trust owns these things. It's really neat. So we can, even before you go in, we can know that, this hospital has great pricing. Let's get you in there. They're going to take good care of you. And so that does help. I think in part of our good contracts, we say this tier 1 or preferred. If someone is tier 1 and preferred, and I'm really getting in the weeds here, but if you're interested, this is good stuff. They have to abide by a couple things. One, the basis of their reimbursement is not on bill charges. They can bill us $100,000 for your CT scan. I could care less. I'm not paying on what they bill us. We run it through. We have to hire a private vendor to come through, run all the claims through it, but basically will say, well, that CT scan in Medicare will be $700. That's what Medicare would pay. Now, again, folks, we're not Medicare. All I can tell you, though, is Medicare is a payer that everyone in the country sees, and it's a good base. The more I learn about Medicare, actually, the reimbursements I think are actually really fair. Medicaid's different, but Medicare, pretty fair. But since we're not Medicare, and we're not large enough to force their hand, we do not get to pay Medicare. I'll be honest with you. If we can pay 2 to 2.5 times Medicare, as crazy as you think that is, sounds high, doesn't it? We still consider that preferred. You say, well, that sounds crazy. Well, I can go show you that with our prior network, we may have been paying the local hospital 400, 500, or 600% of Medicare after their discount. So that's where, even though we're paying 2.5 times, we've been able to kind of control it.
But Blue Cross doesn't care because we're going to pay it anyway.
Right.
We're going to pay that bill anyway.
Tim, I want to address your question a little bit different, with a little bit different perspective than what you just did, because I don't wholeheartedly agree with everything that you said. So I want to give you a different.
Most people don't. So.
It's okay. 3 years ago, and some of you have been in a room where I've made this statement. I'm looking at you, John. I think I talked about this yesterday. 3 years ago, Watermark, my company, was on the exact same, I'm talking, you remember Flow off Progressive Insurance where you buy the box of insurance off the shelf? We both bought the same box of insurance. Had the exact same plan, deductible structures, and oddly enough, almost the exact same census, meaning number of employees and number of lives insured. Oddly enough, our average age was even within 1 year of the average age of the city employee. And I looked at it, just happened, didn't even intentionally do this. Somehow an email came across on my Watermark account that showed what our rate renewal was for that year, and it was very similar to the timing of the city. And I glanced at it, I thought, okay, something must be way off because our premiums were half as much as what the cities were. And I knew we had the exact same plan, it's even called the same plan. Any idea why that is?
Nope.
Because our claims were half as much. So while it may be analogous to other municipalities, it is not analogous to the broader market. What that speaks to culture, and I'm going to offend somebody when I say this, and somebody's probably going to excoriate me like they have in the past when I've made statements on sensitive issues like health insurance, and I'll get excoriated on the Facebook. Go for it. Facts are facts. There is a culture in governments, in my opinion, for whatever reason, whether it's just looked at as a benefit and therefore I'm going to use it and spend it. Now you add on to that the fact, now I want to tell you one other story. 2 years ago, Watermark went away from Blue Cross Blue Shield, and we became a self-insured entity under health insurance. Last year, my son had a motorcycle accident, actually the second one within a year. Broke his foot. We ended up at a hospital, which I will not name. It was a local one within Southern Illinois. Now, self-insured means, in my specific case, I'm paying the claim. It just comes in, check, bill in, check out. I don't send it to an insurance carrier. So I'll go to the hospital and I ask them, how much was the bill going to be? I think I told you this story way back in.
It's a good story.
And they looked at me like I had 3 heads. What do you mean? How much is it? What's this going to be? You told me how long it's going to be, who's doing the work, how long he's going to be under anesthesia, how many stitches it's going to take, this many titanium screws. How much is that? Well, we can't tell you that. We have to disclose that to your insurance company. I said, I am the insurance company. How much is it? Never could get an answer. Until I got the bill in the mail, it was $78,000 for same-day surgery. My point is, nobody, in my case, was negotiating ahead of time, had a plan, had an agreement in place with them. By gosh, if this happens, this is how much it's going to be. I still don't know how they came up with $78,000. Couldn't get a straight answer to save my life. And I was staring them down in about 1/3 the distance from me to you. I'm staring at them going, you can't tell me how much this is going to cost? Coming from a car dealer who is the very first question my customers ask. How much is it? It's absurd to me. The whole industry's messed up because nobody's advocating for.
Right.
And the problem in our environment, and I know I'm going to offend somebody because it's this benefit, because it's always just been there and it's always just paid. You don't even ask that question. I don't mean you. I mean, we don't, as a group, we're not even asking. We're not even advocating for ourselves, much less our employer. That's why hiring somebody to go, you go figure it out with the hospitals. You guys figure out ahead of time what a cost-effective, agreed-on value for foot surgery, for heart surgery, for medication. That's where the savings is going to come, in my opinion, along with these other elements. Because right now, to your point, we've got off-the-shelf insurance. It's either covered or it's not, and nobody's asking after the fact, how much is it? I feel like that's what's happening. That what that does not translate into is immediate savings for us. But we think in 2 or 3 years down the road, at minimum, we think we'll be able to hold the line. That's basically what you said.
Yeah.
The trajectory on a 3% increase on health insurance As tough as it is right now to eat for you and for our employees and for your employer to choke these premiums, I promise you that the trajectory between a 3% increase for the next 10 years and 7 to 11, would you say 8 to 12% is the standard in our world?
Every study I look at,
It's the difference between 10 years from now, our employees being able to afford and have health insurance between that and what I said at the beginning in the plan collapsing. Because what I mean by the plan collapsing, it sounds hard to believe, but think about it. Everybody that's healthy, when premiums are for a single, at that trajectory at $112,000, using my math, which was based on 11%, not 12, which you said was the 112, the employee pays a quarter of it. So that's what? 25 plus 4, $30,000 a year. It's $2,500 a month of the employee share. And the city's going to have to pay $7,500 a month per employee. Nobody's going to be able to afford that. The only people left on the plan are going to be those that don't have any other choice. They got no other option. They're so sick or whatever. That's the death spiral that a health insurance plan ends up in. That's what we're trying to avoid. And I know I'm on a soapbox, but that, again, going back to the why. But
You hit the high points. I mean, we're finishing each other's sentences. I mean, I think we could sit here all day. There's a lot of caveats. You know, Blues own their own pharmacies. I mean, it's wrought with problems. I mean, if you think you're getting transparent pricing and, you know, the money's flowing back to you, you're delusional. That doesn't mean they don't have a great product, and doesn't mean you can't have good renewals. But how do you know? And so I think for us, there's no way I can put my hand on the Bible and say you're running well or we have you where you need to be until the claims run through. And we know that we have squeezed everything out. We're working with the groups. They're going where they need to get. We've worked with staff to get on a plan that better serves them. And that may take liability off the city and the taxpayers. And that's good. Everyone wins. Why wouldn't we be doing this? But we've not done it before. And so work has to be done. The field team is really who we lend the hand to. I mean, they will come in probably unlike any other insurer to where we'll ask to go, you know, department to department, set up times, you know, to meet when it's appropriate, to go over all this, and it may be sitting down one-on-one with some of your staff to go over this. And that's kind of where we're different. But I'll always say I have no idea what your plan's going to be, but nor do you. I mean, all I can say is we're going to blend you with a lot of like-kind entities. We have some really neat tools at our discretion that I don't see anyone else having. It starts with our provider network that we're getting really, really great pricing. Your local providers have, and I think we can prove it, sharpen the pencils for you. I have no idea what other people are paying, short of, you know, I know we were paying before, but for the trust, they've given exceptional agreements to. So as long as we can work with the providers and the members to get them there, I think we're at least going to make it as efficient as possible.
Terrence had a question about that, I think.
Yeah, so my question, I saw you have like 2 different options here. So one question, will this replace our Blue Cross Blue Shield? Okay.
If we go this route, yes.
And then the other one, since I see like 0 deductibles, I'm kind of confused on how do you guys get paid? Will us employees, will we be responsible to pay, let's say 30%? And the city pays the other, or we keep it at 75-25? I don't.
So what your premiums are different than what your out-of-pocket is. So when you talk to deductibles, that's out-of-pocket. And so when you see 0 on that list, right, the tier 1, that means that the plan, it's not me, it's not even the entity, it's the plan. The Hope Trust says by going to those providers that are tier 1, because we know they're giving us such good pricing, why are we worrying about getting $500 out of an employee? Just waive their costs. That's the carrot. Okay, that's what that is. So that's your out-of-pocket. It has nothing to do with premiums. That's your family's out-of-pocket. Same with your co-insurance. So that's why it's so important to go to tier 1.
75.5.
Yeah.
Okay.
What
I did see the 6,000. So
what you pay
that was just a question.
is none of our business. So every entity in the trust has various agreements in place. Some of them have 6 and 7 labor agreements within. That's not our business. What you pay or your dependents, that's a premium. That's for you guys to discuss. What you see that in that sheet is the out-of-pocket, and that's where the trust comes in. And basically it's just saying, if you work with us to go to the providers that we know are giving us the best price, we're going to hand that first over to you. That's savings. That's all it's saying.
Terrence, let me answer your question a little more directly. That we are not contemplating changing that split. We are in discussions into our collective bargaining units, and we'll have to be in discussions as we move forward on future hires, whether we participate in family insurance or dependent insurance. That is subject to discussion and change, but for current employees, that piece that you just said is not contemplated changing. To make it simple, you've got family insurance?
I did, that's why.
How much did you have out of pocket last year, roughly?
Honestly, I really don't know.
Was it more than $100?
Oh, yeah.
More than 1,000?
Whatever.
More than 1,000?
You said for our.
More than 1,000?
Yes.
More than 2,000?
Yes.
More than 3?
No.
So between $2,000 and $3,000
Yeah.
on this plan, if you go to the providers in the preferred network, that's a $250 savings a month for you.
Even if it's
That's the
diagnostic, it's
simplest
not,
way.
You know, you might think, oh, for preventative, you know, might, no, this isn't just annual check, this is any broken arm. It's for.
Yeah, it's me and my 2 kids.
Yep.
So that in your specific circumstance, that's your takeaway. And it sounds like, if I'm hearing you right, almost all the doctors, certainly SIH and Deaconess and all the doctors that
Yes.
are under them, which is most of
Your
them,
big providers are all.
are in that preferred
Correct.
network. They've negotiated those things. Furthermore, if you go to them, because they've negotiated those things in the future, hopefully our claims are less,
Yeah.
instead of me going off and paying $78,000 off the shelf
There's
price.
some hope that just, if you kept everything the same, just because our better agreements, then it may only be 5%, but 5% on, you know, $8-10 million of billed charges, it adds up. So there's some, I don't want to oversell it. It's hard for me to sit up, but I think we've got a lot of really good mechanisms in place to protect not only the entity, but you as a member and your dependents. But
Chief Fitz, you have a question?
I'm speaking just for myself.
sure.
I don't trust easily, and I really don't trust doctors at all.
Yep.
So, it sounds like you vetted the financial part of this pretty well.
Yep.
Do you have a way of vetting doctors to where you can sit down with our people and say, this doctor is every bit as good as this one, and he's gonna save me this amount?
Yeah, we don't get into probably doctor by doctor as much as health system. So it's hard to judge doctors, on that. But it's not uncommon for one of our members to say, hey, I just got diagnosed with XYZ. Where should I go for that? And that, I think, is a very valid question. And it's not even because they don't like their local health system, but the reality is they may not have the local health system the caliber of specialists to deal with that. And so that is where it comes in helpful. I mean, our goal is for you to go wherever you and your family feel most comfortable. And that may be your local hospital, but let's just say it's a very special illness that there is no one in downstate Illinois that even does that, right? So that's where it's helpful to have, St. Louis, whether you know or not, is still a hub in the United States for medical care. I mean, you have 3 or 4 of literally the best and biggest health systems in the country. That's really beneficial. And so we would work with you potentially to go there. We also have agreements with like Mayo Clinic. That is more of a boutique. And so we work with Mayo on you have to go through us to even get there. You will not just be able to go because Mayo doesn't want you. That's part of our agreement. We have to go through a vetting process. Mayo is set up to only get really your hardest cases where no one else can help. That's where you go. And so they'll vet. So if you've got a hangnail and say, I want to go to Mayo, I heard they're good, there's no way we're going to send you to Mayo's for that, but we actually have agreements in place. So I would say we'd rival anyone else of where we can try to get you. I mean, it's going to be our goal to get you where you want to go. And it's kind of driven by you, if that makes any sense. Where do you feel comfortable? So I'm not going to say though that we don't like Dr. Smith. We're not going to get to that level, but I don't feel comfortable with our local health system because this is, a very, very rare genetic disorder. And I feel like St. Louis is where I need to be going to, to WashU or to SLU Care, where they have one of the world's experts. Well, we're going to try to get you there. And we may be pointing that out to you.
That was my main.
Yeah. I mean, we have clinical staff that may be trying to point that out, yeah.
One of your colleagues here has a
Yeah,
comment.
real quick, back to the question the mayor had that started a lot of this conversation was what was our obstacle in Williamson County? What was the biggest thing we dealt with there? Just to be clear, it wasn't just Williamson County, it's every entity that we walk into. It's any government entity that we deal with. Health insurance is personal. Everybody hates change, nobody likes that. Rumors of the worst things that can get going, which is one of the obstacles we dealt with in Williamson County, but we deal with that everywhere we go. Jack and Ted and I are the punching bags. We're the guys out here that's going to take bids. Jake and I got beat up really bad in Williamson County. But it's not uncommon for us to get beat up and take those questions and answer that for the public and for the members themselves. People will look at this list that we gave out and say, well, my doctor's not on there, I can't go. It's like Alex said, there's tens of thousands of doctors. We can't put them all on this piece of paper. If there's somebody that you specifically see that you know you want to go to that's not on here, it's a phone call and you'll reach out to that provider.
Is a phone call the only way, or do you have a web interface that we can search on a provider or a doctor?
So there's a portal system that you can go on and search yourself for that provider. You can call our clinical team and reach out to them, and they'll point you in the right direction.
Okay.
Alex will tell you. So I'm a Vienna boy, grew up in Johnson County, been there all my life, former Johnson County treasurer. 2014, when I was running for office, I sat through board meeting after board meeting, and I listened to Alex present to the board at the time to try to make a change, and they chose not to do that. I was elected in 14. My board chairman asked me, we sat down with these guys and take a look at this. We probably met 3 or 4 times that I beat Alex up because some of this stuff was too good to be true. The HRP was one of those things. Finally, I said, okay, this looks too good to be true, but I talked to a lot of counties that are in it, and they love it. And we made the change. A few years later, I told my board chairman, if I have a chance, I'm going to leave the county and go work for them because I believe in what they do. So I've had the personal experience of being on the other side of not trusting the salesman. Let's just be honest. That's what we are out here. But I just want you to understand that Williamson County is no different than Johnson County, Jackson County, or the City of Marion.
Okay.
Everybody's got questions and concerns that we're going to deal with.
I do have a question I'd like to answer for. I'd like to finish up here in the next few
Sure.
minutes. It's almost 5 o'clock. This is government after all. So,
You said it on me.
I come from retail. I'll stay however long it takes, but the rest of these guys would be mad at me.
I understand.
So, based off your salesman comment, that's what jogged my memory. Obviously, we have a current carrier. We've got a current agent. Tell me what they or anybody else that we might go through would say to sell against you, why we shouldn't go with you. What are they going to say?
Well, I mean, one of the first things they may say is we're not national. I mean, that's a big thing, but, you know, to where, can this cross state lines? Can, you know, what if you're traveling? And so we have protection in place. You think our members, you know, over 15 years haven't traveled, you know, no one lost their house, they were taken care of, no one paid more than what they were supposed to. But we hear that some, you know, because I'm a Blue Cross or, you know, United Healthcare, and we're all over the country. We're the biggest. But I would caution against that. I think you need to be looking at who's going to micromanage your own employees and your needs specifically. So that would be one of them. They never understand the HRP, and I could care less if they do. But that always is a hot topic. I think it very much fuels because they don't have that mechanism to use. It's not that it's rocket science, but you do have to do work, and no one's really doing that. You know, we're not going to be the agency that shows up and collects a premium check and you see us in a year. That's not even how we're set up. You know, we're not your agent. We're the administrator of the whole trust. We're the hired help. You join the trust, we work for you. It's a little different than an agent or broker relationship. The field team may have better explanations. I mean, they're in the field more than I am. That would probably be the biggest topics. And there's some local ones. I mean, you don't think they come into Williamson and they come into Jackson and say they can do better, but those are kind of the high topics, I would say. You know, we're not big enough, not national, and they're trying to peddle. I mean, let's be honest. But the problem with this is, and you guys all know, and I can end with this, but when I joined the firm 20 years ago out of college, I bet there was 15 different carriers that I could go get a quote for. You know, for a small group or individual. I mean, it was just all over. We're down to Blue Cross in Southern Illinois. I mean, you can go get quotes elsewhere, but you know, go ask the local community college. They just went out to bid. And I mean, it's either they're higher than the Blues or they don't even want to quote. Everyone's going out of business. At the end of the year, Health Alliance is shuttering. You know, so this idea there's just so many options, there's not. So, you know, I feel bad for some of your local agents and brokers. I do it. I get it. That's how they put food on the table. But the reality of it is you're selling a broken product, and that's just the truth. And even if you don't believe it, then where's everybody at? You know, there literally used to be a dozen carriers that we could bring in and get quotes. Now whether that fixed the core problems, I'm gonna argue it didn't, but at least you had options. Who are you gonna get? There's no one left. I mean, we have to be honest with ourselves. Go self-fund it, like the mayor does with his company. I'm not saying that's bad, but that's the benefit of the trust. I think the pooling of family like-kind entities has been our saving grace, and it has been for 40 years. But that's not for everybody. Again, a lot of those local agents or brokers, they probably, they don't like that for one reason or another, but I can show with numbers and stats, it's worked damn good for our groups. And we're in a very little niche, and that is local governments in the state of Illinois. I don't know if I answered your question, Mayor. That'd be my best guess.
Yes.
The field team may have, they
So
probably
as
get
it-
darts thrown at them more than I do.
What I suspect happens is with a lot of people, as it has with me, is I'll think of stuff immediately after we adjourn that I should have asked and wanted to ask. So as we all collectively get questions about this funneled to us, what is the best way for us to get those questions to who?
We will give you all of our emails and even our phones. That's probably the easiest. It's direct. Call us. Call us on the cell. Text us. Email.
On a lot of this, so come get them to Cody, Cody can give them to me.
And
The
if,
city,
if
you
we
may-
wanted to set up small group meetings, particularly with bargaining units or non-bargaining units for that matter, just groups of employees, just invite, or even if we haven't yet committed
Correct.
to it. Because you're right, this is personal. It feels like it hurts even if it doesn't type thing. We want to be transparent with it. Everybody go in with their eyes wide open. I feel like I demonstrated with your specific situation, I think the benefits of this for the average employee are so overwhelming. If you stay, particularly if you stay in that preferred network,
Right.
I think it'd be a huge cost savings for the employee on the employee side. The HRP we need to go over more. That's a huge deal.
You bet.
We really glossed over it here in this meeting. It's takes 2 or 3 sittings to understand that
It
thing.
does.
It really does. So I'm just going to hesitate to
But
try
it's
not
the
to.
golden egg. And
Yeah.
I want you to remember that. It
Yeah.
is the golden egg.
Yes.
So I got a son in college, he goes to Everettsville. And so right now we're on the Blue Cross Blue Shield. From my understanding, I can get with you guys or Cody or whoever else, you guys can coach me to help my son to say, you get sick, you get injured, go here.
Yep.
Okay.
There's more protections in place now with the NSA. Yep.
Well, for example,
Yeah, it's-
over by Edwardsville, would be like Anderson Hospital, I think it's relatively closer than Edwardsville. Anderson Medical Group is, and hospital is preferred provider, so if you went there, you should never get a bill, we'll have no out-of-pocket.
But we would most certainly do that, not just for you, but any of your coworkers, that's something we do. I'm perfectly comfortable standing up here in front of a mic to crowds, that's fine. I tend to think that the best education we can do is if chief says, would you come in to my group, I'll have, the guys and girls be here at certain times where we sit down and go over it. If somebody has something really private, specific, we can go and talk to them. That's how we would prefer it, that's how we try to set it up, hence why we have the field team and would work days probably to try to go through all of the departments, meet with all your staffing as you see fit. That's what we do in most of the groups. Every group's different, some want to get a big room and fill everybody and we do it that way. I tend to think that probably more private, personal meetings are better. It doesn't have to be one-on-one, but by department, that seems to work best.
People tend to ask questions around people they're comfortable with, so if you're in a big room, it's difficult, but if we had to go to the police station or fire department, if there's 3 or 4 different shifts we need to take care of, we can, but people, we've learned are more apt to ask questions when they're around people that they essentially work with and not long term.
And correct me if I'm wrong, and this may address a little bit of your angst there, but we're obligated under our current arrangement with Blue Cross through the end of the year, right? So the reason we're talking about this now is so that there is a runway to answer all these questions, have these meetings. Everybody understands it. We would have to make the decision prior to December 31st to get going on that. That's kind of where we're at. But this is not a faucet or a light switch that you turn on and off that you all of a sudden tomorrow have to change what you're, I don't think it sounds like you'd have to change much anyway, but just rest assured, that's why we're having this discussion now openly and trying to get everybody at least on the same page as to what our options are. If we ultimately go this way, which is not a decision we're making at this sitting, for sure, we've got a 5-month runway before you'd have a new card in your wallet, so to speak. Does that make sense?
if we were decided to go with you, do you decide, or the executive board, or peer members? I'm just curious, who makes
We as
decisions?
administrators
Okay.
will decide, and for the most part, I mean, you hit the main criteria, you have to be an Illinois local government. And we will, do medical underwriting, we'll work with mainly the management, we may ask for some of the Blue Cross information, but, we don't buy the business, and we're not, it's somewhat informative to know where you're at, certainly want to know what plans you're on, but no, the executive board doesn't have to approve.
Okay.
No, we have full discretion in doing that. And while we can work, and we went over this in the meeting, and I was a little growly with Cody and the mayor, that the sooner we can work on this, not because I want to push it, we can work off of a handshake and have in the last hour, but our experience has been the farther out we can push this to where we can meet with the staff and get everybody comfortable. Certainly if you're going to offer different plan choices that they've never had before, they need time to think about this, talk with their family. No one wants anything rushed. They're already scared to death of change, and I don't blame them. But rushed is not the way we like to do it. We've done it, and as the field team will tell you, it's messy, and we get it done, but yeah, we want to make sure that the new ID cards are in everybody's wallet or purse. They feel a lot more comfortable. Not that Jan 1, they're going to expect to go to the hospital, but boy, people are a lot more comfortable if they feel like, they got their card in hand, they're fairly comfortable with the coverage and who they're going to go to. Maybe they've chosen a new plan that they've never had before, but they understand it, and that just works better. So hence why we're here in July and still talking about it, because we don't have to have a decision tomorrow. But the sooner we can start gearing up, we will start deploying resources to, really come out to the office and start meeting. That's how we like to do it personally.
Well, I would suggest that we circle back, Cody and I, and you guys have another meeting. I'd like to nail down the proposed premiums, go over these plan choices. I want to one more time understand this HRP thing, because that's where a lot of these questions will come. I think that's the golden egg thing again. I'm sure because we put this out there, we're going to get some commonly asked questions, and we need to compile those. And then if we can get that presented by the next meeting, and then maybe if we had a decision, if they want to go this route by the end of August, does that still work? And then what we'll do is rally around those commonly asked questions and get with you guys on what the best way to organize. Use that 4 months, 4.5 months, whatever it turns out to be, as our runway to meet with smaller groups, or I think individually, actually, a bit more individual, because this HRP thing is a very individual thing, right? Is it, do you have coverage elsewhere that you can get on, and look how much this will save you if you go this route? I think that's not a group discussion, for
And
example.
it sounds like you'll have us maybe one more time up here where department heads will be present, but one thing I would ask, and we'll work with labor too, they've been a huge help with this, but when we deploy the health apps, please encourage all of your coworkers, or if they're under you as a FAR staff, to fill those out. They're kept 100% private, they're disposed of when we're done, but we garner a lot of information. Back to the HRP, that is a big way that we can start seeing, is an employee possibly eligible for this HRP? And I'm telling you, it's a benefit that could save the employee and their family thousands, and they've never had it eligible to them before, so they don't even think about it. But we have some questions on that app that could do it. So I'm just gearing up that if we are chosen, and we probably will have another meeting beforehand, but I can't ask enough, if you're a department head or a labor representative, please encourage your members to work with us. And if you have questions, come to us. I want everybody comfortable, but when folks kind of throw it in the trash, it's electronics, we don't throw it in the trash, but you get what I'm saying. When they don't abide by it, it's a little tougher for us to know where we can try to save not only the entity, but the employees themselves. I mean, that's the first one. The employees are always going to win first. There's just the entity cannot save money if we don't save the employee money first. It's that simple. And that's how the employees should see it. But we do need to work with them on that.
Okay, does anybody else have just a begging question?
It just doesn't matter, but I'm the county board chairman for 12 years, and I know where you guys are sitting and what you're thinking. The biggest thing I can say is the way we come in, and you mentioned the car. People know the price of the car when they come on the lot. What we want to do is to quote Alex, make consumers of healthcare out of your employees. We want them to know what's going on. We want to educate them. And when I was chairman, that's what they did with our employees. And when that education comes, it runs smooth, as it did in Williams. They just educate.
Thank you. You guys have any begging questions at this point? I know it's a lot at one setting. Anyone else in the audience for?
They leave some packets up front.
Okay, there's plenty of information up here on the front row. Thank you all for your time. Thank you for your overtime, those of you that are here. And thank you guys for attending the special meeting. Oh, I'm sorry.
Somebody had a question back here, or not? No? Good.
No,
We need to make a motion.
I would entertain a motion to adjourn the special meeting.
I make most to adjourn.
Second.
Roll call, please.
Commissioner Patton?
Yay.
Commissioner Barwick's absent. Commissioner Webb?
Yay.
Commissioner Stecklin?
Yay.
Mayor Absher?
Yay. Did you say that about the leave?
So you get up.